Well, welcome, ladies and gentlemen. Thank you very much for joining us on the second webinar from the Coalition of Centers in Global Child Health. And today we have a fantastic topic, important topic on the issue of childhood vaccination in low and middle income countries, especially in relation to the COVID-19 pandemic. And the moderator for this session is my worthy colleague and fellow executive member of the coalition, Dr. Tobias Alfvén. And Tobias needs no introduction to people in the field. He is an associate professor in health systems and policy, global child health, and importantly, sustainable development goals at in the Department of Global Public Health at Karolinska Institute in Sweden, Stockholm. I'd also like to point out that the coalition is indeed, as the name suggests, a coalition of 48 centers across the world with a principal focus on trying to help improve global child health in the Sustainable Development Goals era. It was set up explicitly to improve academic collaboration, capacity development, exchange, and research between various academic centers across the world focusing on these issues. A very important partner of that is also the International Pediatric Association. We're very grateful that the executive director of IPA, Dr. Naveen Thacker, is also with us today. So without further ado, and without taking time away, let me pass the floor to Tobias.
Thank you very much, Zulfi. And again, a warm welcome to all of you that have joined us today for this webinar. And as Zulfi said, the theme is childhood vaccinations in low and middle income countries during and after the COVID-19 pandemic, because there will be an end, hopefully, to this pandemic. And the COVID-19 pandemic has, as you all know, spread to all countries in the world and has in many countries devastating both direct and indirect effects. And as we all know, the direct effects on children's health have been rather limited. However, the indirect effects are massive. Examples are closed schools, food shortages, decreased access to health care, and also disrupting immunization services around the world, putting millions of children at risk of diseases like measles and many others. And since March this year, routine childhood immunization services has been disrupted on a global scale that I do not think we have seen since the inception of the expanded program on immunization, EPI, in the early 70s. And now, during the coming 90 minutes, we have the time to listen to 4 world-leading experts in this field and discuss both challenges and hopefully also some opportunities that the pandemic might give us and how we can use that to increase coverage and better childhood vaccinations. So I'm very happy that today we have Dr. Naveen Thacker, Director, Deep Children Hospital and Research Center at the Gavi, Gujarat, India. And as Zulfi said, he is also the Executive Director of IPA, the International Pediatric Association. Then we also have Dr. Nandy, the Principal Advisor and Chief of Immunizations at UNICEF. A warm welcome to you as well. We have Ms. Anuradha Gupta, the Deputy Chief Executive Officer at Gavi, and Dr. Altaf, the National Technical Focal Person at the National Polio Emergency Operations Center in Islamabad in Pakistan. But before we start, just very brief technical input to all of you that we hope that we get a lot, and I'm sure we will get a lot of questions. We keep the questions and try and answer them after the 4 presentations, but we will use, as you can see, the question and answer at the bottom of the Zoom link. So please press that one and you can start writing your questions already now, but we will try and answer them all at the end of the presentation. With that, I would like to give a warm welcome to our first speaker, Dr. Naveen Thacker. A warm welcome.
Thank you, Tobias. Can you stop screen sharing so I can start mine? Yes. So thank you so much, Zulfi and Tobias, both of you, for inviting me for this very important topic. And as other speakers are going to cover how the services are affected and what is going on, I will try to focus on vaccine trust, which is the key word and very important in both during the time of COVID and after that. So this is outline of my presentation where you can see the challenges in red, and but there are definitely some opportunities. Now, recently we had a WHO conducted a global conference on infodemiology, and many of these slides are coming from there, from mostly from two speakers. Coming to my first slide, I would like to share with you what are the global misinformation trends, because there is one pandemic of COVID, but there is also another epidemic going on, which is we are calling as infodemic. And so we must know what are the global trends. These are the slides from the Claire Wardley, from the first draft US director for the first draft news. And these are the some of the worrying trends which we are seeing. The first is closed messaging apps and groups continue to be spaces where misinformation and conspiracies are being shared widely. And mostly the main out of this, the main is the what we have WhatsApp, and we popularly called it WhatsApp University or Dr. WhatsApp, which is the main source of misinformation. And as this is end-to-end encrypted, we cannot monitor this and can't do anything. So that's yeah. So that's the first thing. And second is about the fabricated information. You know, the fake news, hoax continues to be highly effective tactic. These are, if you can see two examples, one from the India, Mumbai, where the logo of Municipal Corporation of Bombay is used to spread some news, and another one where they have used the World Health Organization, CDC, and everything. And as I said, there is a so much abundance of information or infodemic, and otherwise also our brain is not accustomed to say analyze the information fast, and in this infodemic it becomes more difficult, and we all tend to use heuristic or mental shortcut to make a judgment whether information is genuine or not. And whenever we see a logo of a trusted organization, we feel this is a trusted information. And that's how it becomes a very highly tactic that you can use, and this circulates on WhatsApp groups and closed circuits, and you just can't do anything. The third thing is misinformation and hate speech continue to intersect. People are taking advantage of existing racial division, xenophobia, and also in lower and middle income countries, the social divide, which they continue to explore and continue to circulate, take advantage of that. The fourth is, you must have seen this pandemic, visual and mimetic and video content is getting more prevalent and influential, but much more difficult to monitor. For researcher, this is a real headache, because it's very easy to research the text information, but it's not easy to say monitor the videos and analyze the videos. And when it comes from, like, this was produced by Netflix, so once again heuristic comes into play here. When you think that it is a professional work, and we continue to believe that. The last thing which I want to highlight is the conspiracy theories, which were till now were inside the fringes and now moving up to the mainstream. And you can see one example of this 5G, how it has percolated into the mainstream and real world, and where now people have started attacking the telecom engineer and continue to demonstrate and destroy the say 5G mast everywhere. So this is really worrying, and this continues to get traction, because there are, conspiracy theories are nothing but emotional stories. And when you don't have explanation, when you have information or gap, trust, the true information. Like we are not, still it is continues to be debated whether this is a man-made virus or from where it came. No treatment is available, no vaccine is available. Even this is not, there is a debate whether we should wear the mask in the closed meetings or not. So this is the time when conspiracy theories gets traction and people try to believe, because this matches with their previous beliefs and what they think, and these emotional stories gets place, and they are tend to believe because they are losing their job, they are frustrated with the lockdowns, and this they become more susceptible to believe the conspiracy theories. Now social media has made it worse. You can see the exponential growth of social media data, and now we have 3 billion user of Facebook and 350 million plus user of Twitter, and leave aside other social media and local, which also provide services in the local language like TikTok and all that. So it is impossible now, and this has become so exponential that previously we used to have rumors in one part of the world, but now with social media we have same rumors circulating, traveling from US to India or from India to US at the same time. Dr. Neil Johnson from Washington University has done a good research. And just to give an example, when a study of anti-vax sentiment on Facebook was focused on page of a local pediatrician in US, but what they found out that there were commentators who attacked him was from 36 states and 8 nations. And coming more, this is a online, this is a good paper which Neil Johnson and group has written in Nature, published some time back, where online competition between pro and anti-vaccine views, and what is predicted with a mathematical modeling that in next 10 years, the anti-vax people will dominate and will definitely have much bigger hands. Why they are saying that? When they analyze about this 100 million users, which are, and did the mapping of the Facebook, and they this is every dot is represents a cluster of Facebook page, and where here you can see the red are anti-vax, the blue are the pro-vax, and 74 million out of this 100 is undecided. But what is interesting here that though the number of anti-vax is less than pro-vax, but pro-vax continues to talk to each other, and they are not communicating with these green ones, while the red one, the anti-vax people, are very well connected, and they talk to these green ones and go beyond their say their circle and also talk to others. This is worrying trend, because these green ones who are decided, mostly parents groups and parents association, are one. If we are not talking to them, naturally many of them can turn to the red, and that's why they said within 10 years it will take over, and definitely they are winning the battle if we don't do anything. And another worrying trend is the joining of hands of the anti-vax people with the anti-lockdown and anti-government, anti-establishment people. And you can see here when from California, the anti-lockdown people were also carrying the anti-vax play cards. Now, so if a vaccine will not work, because as they say, vaccine don't save life, vaccination does. So if we talk about any vaccine, and I will come to that, why it is important and it is threatening the whole immunization program. But this is an example where 1 in 7 are saying that they will not take the COVID vaccine. And this is because they distrust in vaccine in general. So as I said, it's all about trust and getting communication right. It is very important that whatever we do, the people are watching and they will see how the government are tackling the COVID crisis, and also the communication, because the message which is going now that COVID vaccine being fast tracked, and this gives opportunity to these people to group themselves and attack the vaccines in general. So now, as I said, WHO Director General after declaring pandemic, also declared there is another epidemic going on, which is infodemic, which is abundance of information. And that's why they conducted first WHO infodemiology conference, over which was held over the 15 days. I was fortunate to represent IPA as one of the 110 experts, and we had many sessions to discuss. And finally, previously it was that how do we learn from epidemiology, and how do we build glossary and approaches? But it was very clear in first meeting that this is a transdisciplinary approach where you have epidemiology in public health, applied math and data science, digital health, social and behavior science, media studies, marketing, and so many other, risk communication, law and governance. And this is the suggestion which has come, and this is still work in progress. So doing surveillance, social listening, delivering high quality health information, and others. I would highly encourage you to go to WHO website, and all the presentation and all the recommendations are there, and it's very interesting, which will give you insight how to tackle this infodemic. And second, lastly, I want to say that it has come again and again that healthcare professionals are key in changing the conversation. Whether this was a study during the polio eradication or a recent study in New York, where again they said they will 17% or so said they will take vaccine, but another 30% or so said they will take vaccine if it is recommended by a healthcare professional. Our misfortune is that at currently the COVID response is led by the politician and administrators, not by the scientists, and that's very important. If we want to build trust, we will have to see that we empower healthcare professional, and scientists should take the lead. Now, healthcare professional recommendations is major driver, but they mostly underestimate their importance of recommendation. And many, and if you see this slide, they underestimate their influence. They have low actual perceived or self-efficacy to influence a decision, have decreased time. It was in one study, it was found they interrupted the parents every few seconds, and they use prescriptive factual language to address the inquiries. So it's not easy, and we need to empower medical professionals, need to learn behavior-centered communication techniques, interpersonal communication skills, social media engagement. As I said, we have a large unoccupied space on the Facebook and social media, and if we don't become active on that, and then definitely the other peoples are going to win, because they are very organized. Media management also, whenever any misinformation spreads, it is the medical professional, pediatrician who are asked to give their opinion, but we never got this training in medical school, and most of the time we mess up. So we need to train them systematically, and this is what International Pediatric Association is doing. We have a we have a IPA vaccine trust project. It was started as IPA vaccine hesitancy project during Dr. Zulfikar Bhutto's presidency. Now we have named this trust project, because trust is the key, and we are launching this next month. And we have 1 million pediatricians around the world, and gradually with this online, the more openness to online learning, we will be try to reach as many as possible, and we will play our part in contributing to tackling this infodemic and misinformation. And as I said, this is my last slide, that vaccine acceptance post-COVID will depend. It's a challenge, but it's also a great opportunity. People were never so open, positive for the public health. They were never talked about the vaccine, never talked about the mask, but they are very open. And this is how, as a whole community, scientific community, politician, administrator, everyone, how we play our role will depend how we communicate. We don't give false promises. We give, say, a forum to the scientific expert to lead the responses, and then only we will have we can convert this into an opportunity in favor of vaccine. Otherwise, it is not only the COVID vaccine, but it is going to affect all the vaccine even after the COVID is over. So it's a long way ahead, and definitely we have to play. All of us have to play our part. Thanks to all these people, and thank you so much for giving me opportunity. Thank you.
Thank you so much for that presentation, both giving the background to the infodemic and all the issues related to that, and then also some possibilities how we can tackle that together. And that's an excellent way moving from that to Dr. Robin Nandy, the Principal Advisor in Chief of Immunizations at UNICEF. A warm welcome, Robin. You're on mute, Robin.
Hi, after all these months of Zoom, one would imagine that I have figured out how to unmute myself. But I hope you can see my slides, and thanks Tobias for the introduction, and really happy to be with you all today. I was scanning the participants and I see a lot of old friends, so greetings to everybody and thanks for joining. I know it's a really busy time for everyone. Following an excellent presentation by Naveen, I'm going to now walk us through where we are in terms of global immunization in the context of COVID-19 pandemic. We have stopped talking about COVID and post-COVID. Now we know that COVID is going to be with us for a while. And so, we have to adapt to these new realities. In addition to challenges, we will talk a little bit about the opportunities as well. So I'm going to try to be as brief as possible, and so that we can have time for discussion. But I will basically talk about the status of immunization programs, some of the impact of COVID and disruptions that we have seen over the last several months. Talk about some opportunities. I think important that we don't get mired in very dire, negative, pessimistic situations, and actually, use the old saying that never let a crisis go to waste. A crisis provides an opportunity to do some things better and differently. So we'll talk a little bit about that. But before I go to COVID-related impact and disruption, it's important to reflect where we were prior to COVID. And last week, 15th of July, WHO and UNICEF released, as we do on an annual basis, data from the previous year. So we released the 2019 what are called WUNIC estimates, WHO UNICEF estimates of immunization, national immunization coverage, and you can see here, and again, most of you are very familiar with this. I mean, immunization has made huge coverage gains over the last 20, 30 years. But over the last 5 or 10 years, the progress is stagnated. I mean, we have reached coverage in the mid-80s. The proverbial low-hanging fruit has been exhausted. All the kids that remain unreached now are in challenging contexts, and are underserved or untouched by the health system and health services. So where are these remaining kids? And we've got a fair idea of what countries contribute to the numbers. Of course, you have got a group of countries which contribute large numbers: Nigeria, Pakistan, India, Ethiopia, DRC, Indonesia. And then you've got the group of countries which are smaller. So the absolute numbers are not as great of unvaccinated and under-vaccinated kids. And here I'm using the data on unvaccinated kids, so what we are calling zero dose children, which helps to actually focus us on where the problems really lie. So zero dose definition here is a child who has not received DTP a single DTP dose. So largely these unvaccinated kids are in the African and South Asian region, and of course, smaller numbers in other regions as well. Now, where are they? And I think the UNICEF and the Gates Foundation chair what is known as the Immunization Equity Reference Group, of which our Master of Ceremonies, Zulfi Bhutta, and one of the speakers who comes after me, Ms. Anuradha Gupta, are members of. And this equity reference group, tried to characterize the kind of communities where these zero-dose children exist, and the purpose of this is to make it real in terms of program implementation. So once you can visualize the kind of communities where these kids are, it becomes clear what implementation modalities are relevant. So a large, we think a large number of these unvaccinated kids are either in remote rural areas, urban slums, or in areas affected by conflict. Above, you can see a table of pretty preliminary data from World Pop, University of Southampton, and Gavi Secretariat that tries to quantify the number of unvaccinated kids in these different types of contexts. We do have issues with data coverage, data availability, particularly subnational estimates. But I think the available data that we have and the other programmatic evidence and what we see as we implement programs is that these three kind of communities have a major bulk of unvaccinated kids, and gender plays a huge part. And I think we got much more sophisticated in the way we look at gender dynamics around vaccinations, beyond gender differential in immunization status, which for years we used as a marker of the gender impact. So this is pre-COVID. So so what happens with COVID? And you can see here, this is a pulse survey done by WHO, UNICEF, Gavi Secretariat, and the Sabin Institute's Boost initiative. We have done 2 of these pulse surveys since the start of the COVID pandemic, and it shows major disruptions. This shows decline in coverage in May compared to the first 2 months of the year. Obviously there is disruption to both fixed post vaccination services. But if you see this, outreach services are most impacted. And what that means is, we expect there to be greater equity gaps in the context of COVID, because, outreach is one of the main strategies to reach these underserved communities. We have also seen this in various administrative data. You see coverage drops. The first quarter of this year compared to the last few years. The pulse surveys also generated useful, qualitative data on why people were not receiving vaccines. And again, not surprisingly, even when vaccine services were in theory operational, people were not seeking these. Why? Because they were either unable to reach the vaccine services because of lockdowns and transport interruptions, or they were unwilling to risk going out to a health facility, risk exposure to patients with COVID-19, and so they were not going out for routine services. There were also the issues of health workers being scared for their own safety and health, and lack of personal protective equipment, and so on. Campaigns were severely disrupted. WHO recommended this temporary suspension of all campaigns, because we didn't want to contribute to the spread of the COVID-19 pandemic through the campaigns, which require, as you know, a lot of people coming together. Since then, this guidance has been nuanced and on a case-by-case decisions being made to implement these campaigns and particularly outbreak response activities. From a UNICEF perspective, as the largest supplier of vaccines procurer and supplier of vaccines, we really struggled with the transport disruptions, and we saw our vaccine shipments to countries drop by a fifth of what we would normally expect to see for that particular time of the year. Fortunately, we were able to, really map and prioritize the stock. So while some countries had stockouts at central level, at the service delivery level, we didn't see too much impact in terms of shortages, barring a few antigens in a few selected countries. But we are tracking this very closely, and we'll need to continue to track this. So I want to now shift to opportunities, and we're talking about not letting a crisis go to waste. Where do we see an opportunity to reimagine or build back better, whatever term you choose to use? We have multiple guidance documents now developed by WHO, some of which are joint WHO-UNICEF documents, which have been sent out to countries, and now the challenge is to support countries in implementing these. We have also put our heads together with WHO and the Gavi Alliance to look at, what does a reimagined immunization look like? We understand that the changing context, COVID-19 impacts everything. It's going to impact supplies, outreach services, as I mentioned, but the economic impact is going to be substantial. We expect falls in GDP. We expect constrained health budgets. We have to think a little bit differently about how we get bang for our buck with available resources. And here I'm talking about resources, country resources, domestic resources. Resumption of services will happen in a patchy, uncertain manner, and the inequalities we've seen that I've shown you earlier are going to be exacerbated. It is those things like outreach services and campaigns are going to be the last thing that is going to pick up, and it's going to impact equity. And the COVID response is going to also impact on the trust within the entire health system, which is going to impact immunization services. So our four-pronged suggestion is, obviously restore and revitalize health services, address immunity gaps caused by the disruption. So this is the catch-up phase. Expand it to areas that we were not reaching in pre-COVID times, and which will be exacerbated now. But also link it up with planning for a COVID vaccine once it becomes available. And it's better to see it as a continuum rather than patchy, independent, unlinked pieces of work. So build back better. What do we talk about in terms of opportunities? Perhaps more efficient service delivery, which will be needed in the context of COVID. Maybe smaller session sizes, reduced waiting times. Perhaps we can't have mothers waiting 3 or 4 hours. Waiting for their kids to be vaccinated. Better IPC practices. I mean, we've had an issue with antimicrobial resistance. We've had problems with infection transmission within health facilities, and we can do things to address that. Other opportunities, including putting water and sanitation in schools and health facilities. Adopt an integrated approach, and I think you're going to hear later from my colleague Altaf Bosan from Pakistan, Dr. Altaf Bosan, who will talk about polio. But we are working with all the disease-specific initiatives: polio, measles, yellow fever, meningitis, to look at integrated approaches to delivery that would be more efficient and effective and respond to community needs. And I think, and it's important to continue the focus on zero-dose children. And we are making this shift of zero-dose children to zero-dose communities, the assumption being that the zero-dose children are not randomly distributed in populations, but are clustered in certain kinds of communities that I've described above. That makes it real that, that these kids suffer multiple deprivations, and it provides an opportunity then to link up with broader primary healthcare services. So adopting a systems approach, Gavi Alliance and supported by Gavi Secretariat has been extremely proactive in looking to see how Gavi investments can support broader health services, cold chain, supply chain, how immunization cold chain can be adapted to respond to the needs of other temperature sensitive health commodities. The whole issue of vaccine misinformation is a huge area of work, as Naveen described, and I can't emphasize it enough how important that's going to be. And the emphasis on service quality and experience will, if done correctly, enhance trust. And this is our hope. As Naveen says, the trust is extremely key. So to a certain extent, and to a large extent, trust in the health system can mitigate a lot of the impact of the misinformation. You are likely to believe in people and systems that you trust, and not get swayed by misinformation if there is genuine trust. So the types of service delivery strategies are going to be critical. We will need all the tools in our armory, fixed sites, intensification of routines, campaigns or supplemental immunization activities, and of course, outbreak response. And then, this is then, I want to end with and this is a good link up with Naveen's presentation, is I think we have to look at the health system as a whole. Addressing demand and acceptance to vaccination is not solely a communication problem. Communication is a really important part of that, but it is not a communication problem. It is a problem of trust in a health system, quality of the health system, convenience of the health system, responsiveness of the health system to community needs, engagement with the community. So this is basically showing you in graphical point, a 6 point of intersection which are extremely critical to improve demand. My final slide is again to reiterate some of the points I've made. The COVID pandemic provides an opportunity and a necessity. The economics will drive us, a necessity to push real integration between programs, and this involves us all at global level. We are all partners of these initiatives: the Global Polio Eradication Initiative, the Measles Rubella Initiative, the Ending Yellow Fever Epidemics. Eliminating yellow fever epidemics. So all these vertical programs, we need to think a little bit differently, look at it as an opportunity and a necessity. At an implementation level where the rubber hits the road, look at opportunities to bring these all pieces together. We need to deliver services in a safe manner. I talked about the human-centered design, the 6 points in the previous slide. You all may know that we are in the process of finalizing the Immunization Agenda 2030, along with WHO and partners, and this really provides an opportunity. And when I'm speaking about integration here, I'm not only talking about integration within immunization, but integration of immunization within a broader range of primary care services. These zero-dose communities are deprived of everything. Immunization, broader PHC services, education services, sanitation services, and we could use immunization as an entry point to make these communities visible to other programs as well. It's not like that immunization is going to increase their scope to address all these needs, but we can provide the entry point and the data and the visibility for these communities in order to do so. And then my final point, which is a good segue to the next presentation by Anuradha Gupta, the Deputy CEO of Gavi, is that in Gavi, following a successful replenishment, and thanks to everybody for that, and I thank on behalf of Anuradha as well as an alliance partner, a successful replenishment, they are the resources, and Gavi provides a mechanism to actually drive some of these changes at country level. Thank you. Back to you, Tobias.
Thank you very much, Robin, for an excellent presentation and showing what the situation looked like before the pandemic, now during the pandemic, and also discussing some challenges and opportunities. And before I hand over to the next speaker, I've seen some of you have started using the Q&A. Please continue, post your questions there, and we'll get to them after all the presentations. Now, I'm very happy to present the next speaker, Anuradha Gupta, the Deputy Chief Executive Officer at Gavi. A warm welcome to you, Anuradha.
Can you hear me now? Yeah?
We hear you very well.
Okay, all right. So thank you. And my task has been made easier by Robin, because a lot of things that I wanted to say have already been covered. So I would be rather quick in my presentation. If you could go to the next slide, Jessica. This is just to give you a perspective that till 2019, we have seen an improving trajectory on routine immunization, and it's been very impressive progress. But as Robin said, the last 2-3 years, we haven't really made the kind of progress that we were hoping to make. So in 2015, we were able to reach 63 million children with the third dose of DTP. And in 2019, we added 2 million more. So it's good, but it's not good enough for us. And it is definitely lower than the target that we had set for ourselves. So really the key message here is that already we were plateauing on making further inroads, particularly into poorer households and communities. And now, given COVID-19 situation and disruption that Robin talked about, there is a grave risk of backsliding. And some of our projections are showing that if remedial measures are not immediately taken, the 65 million number could come down to anywhere between 37 million to 50 million. So clearly, that's a sort of an alarm bell and a wake-up call for all of us. Next, Jessica. So I also wanted to give you a sense that on breadth of protection, we have done extremely well. So I think the Alliance as a whole, countries that were supported by the Alliance, actually put a lot of effort in introducing new vaccines and expanding the breadth of protection. And we have seen some remarkable sort of progress on the second dose of measles, rubella introductions that happened in a lot of countries, IPV scale-up, which was phenomenally, sort of rapid despite supply challenges. And you can now see that in Gavi countries, the coverage of Hib, pneumococcal, and Rota is actually higher than non-Gavi countries. But we know that because of COVID, as Robin said, new vaccine introductions and preventive SIAs have indeed sort of taken a hit. So we were planning 68 new vaccine introductions and large-scale preventive campaigns, which really included measles and rubella introductions, and 45 out of them have already been either postponed or cancelled. So I think we have a challenge there. Next. So Robin spoke about this very eloquently, and I'm just repeating the same message that of course we have seen some very, very good encouraging progress on reducing the number of zero-dose children. This is a new concept, that we are all now embracing and socializing, and zero-dose for us means that that child who has been deprived of even the first dose of DTP vaccine, so not a single shot of DTP. And as Robin said, the whole idea is that that zero-dose child is a marker of acute inequity and actually guides us into those communities that are suffering from compounded vulnerabilities and multiple deprivations. So here, what is interesting to see is that even in non-Gavi countries, actually, the situation is becoming extremely sort of worrisome because in Gavi countries, we're still making some progress. So we actually reduced the number of zero-dose children by 14% since 2014. However, the sad fact is that the dropout rate between DTP1 and DTP3 stayed flat at 7%, which really means that though we established a touch point with poorest households and zero-dose children, we were not able to bring these children along with us on immunization journey. But on the other hand, in non-Gavi countries, actually the number of unimmunized children, zero-dose children, and children who do not receive the third dose of DTP has gone up. So I think for global immunization community, again, it's a grim reminder that of course, within Gavi subset of countries, we have some serious formidable challenges, particularly in fragile countries, but outside Gavi world of countries, there are some worrying signs. Next. So a few large countries actually have contributed to reduction in zero-dose children that I just highlighted. The good thing is that we have seen some great momentum in large countries such as Nigeria, India, Pakistan, Ethiopia, Congo, DRC, and Congo DRC has been adjusted downwards, and still overall we see a bit of a positive swing. But what we try to do as an alliance during the last 4 or 5 years has been to actually strategically engage with the highest echelons of political and executive leadership to make immunization a foremost priority for countries, so that countries take greater ownership, they provide for domestic budgets, and they actually pay attention to program management and monitoring. And I think that has actually shown some very positive results. And those countries that we engaged with more intensively have shown some positive swings. However, we do see now signs of backsliding or stagnating performance, because one, these countries have come under severe fiscal stress, as Robin alluded to. So the economies have taken a hit. They are in a tailspin. The ability of countries to maintain domestic investments in immunization and primary healthcare more broadly, is going to be extremely challenging. And I think, therefore, we need to really think about some of approaches which do not sort of weaken country ownership of a critical priority like immunization, and yet gives them some sort of succor, which is helpful. Next. So how did we step in to support countries as this pandemic started to spread? And you might have already been aware that the spread of COVID in Gavi-supported countries has been slower than the rest of the world. So really in Asia, we have about more than 70% of cases, and that too in India, Pakistan, Afghanistan, Bangladesh, and to some extent Indonesia. But I think Africa sort of did not see the same kind of trajectory as the rest of the world, and that did provide Africa a bit of a window of opportunity. We can't deny the fact that there was fear. The countries were in a state of flux. They were suffering from uncertainty, but I think that gave us an opportunity as an alliance to step in to actually prepare countries to respond to the rather gradual spread of pandemic. And what we did was to actually offer immediate sort of reprogramming opportunity. So we do support countries with health systems grants, and our total spend in these last 5 years is about $1.4 billion. So out of that, we actually permitted countries to reprogram very quickly, monies that would be required to immediately respond to the pandemic. Now, the good thing here is that countries have been extremely thoughtful about this, right? And overall, it is only 60% of what was admissible to them for reprogramming that they actually reprogrammed, and there was a very strong message from countries that they would much rather, focus on maintaining routine immunization and strengthening it and not take away the money from critical immunization activities, which I personally thought was a very, very positive message. But that said, you know, the money that was reprogrammed, more than 50% of that was for infection prevention and control. And the rest of it was for risk communication and surveillance, case-based surveillance and community trust. We also realized that there was disruption, right, in supply. Global supply chain almost collapsed. There was a point in time, and chartered flights had to be organized, and therefore we've coordinated with UNICEF Supply Division and provided additional funding for chartered flights. Another innovative mechanism that very quickly resorted to was a pre-financing arrangement with UNICEF Supply Division, where we actually gave them about $40 million to procure personal protective equipment, gloves, and diagnostic kits for countries. Because you would remember there was such a scramble in the global market. The prices had shot up, and countries would have been really at sea, you know, figuring out how to access those critical commodities. And I think UNICEF, as a result, was able to actually contract with 4 suppliers and make sure that countries had access to those very vital commodities. We also sort of brought about some fast track changes in our policies, and the board was extremely supportive, you know, and I think the encouragement from the board was that we should absolutely be flexible and immediately we, for example, one compelling example is that recognizing the fiscal stress on countries that we support, the board decided to freeze the transition status of all countries and also freeze co-financing levels, which really gave a lot of reprieve and respite to countries which would have seen increasing levels of co-financing. The board also authorized us to consider selective waivers of co-financing. But as I stated earlier, we have been very wary of invoking this on a blanket basis, because as an alliance, we have invested the last 10 years in building country ownership and domestic financing of immunization. And therefore, we have been reaching out to World Bank and all other partners, including IMF, to figure out how can we provide interim finance to countries, you know, so that they can maintain their domestic spend in immunization. And we have been very successful, I must say. Like in DRC, we succeeded with the support of World Bank and IMF to maintain co-financing. In fact, DRC paid up its entire co-financing amount due for 2020 about 2 months ago. So country by country, you know, looking at the fiscal position and working out mechanisms to make sure that we keep the domestic commitment to immunization extremely high. On processes, we became extremely nimble. And that is what, you know, when Robin says, you know, a crisis should never be wasted, you know. So I think we actually leveraged this crisis to pressure test, you know, nimbleness in terms of our processes, which can be extremely tardy and bureaucratic at times. And so when the reprogramming requests came, we were able to approve them within 5 working days. We also sort of spend more than $1 billion every year on procuring more than 500 million vaccine doses for countries. And we made sure that this time our renewal of vaccine doses for countries was extremely light touch. And of course, we add on the side of sort of oversupplying and not questioning too much, recognizing the challenges that countries are facing. But I must here share with you that we are worried, because we think that overstocking in countries is a growing risk. And that is why when Robin presented that slide, I think making sure now that stock reporting from subnational levels becomes a continuing process is going to be extremely important, because when we are nimble and flexible with our approvals, we also need to make sure that with that on-ground sort of monitoring of how program is playing out is going to be critically important. Now, another thing that we did was repurposing our partnerships. So we have put in place a partners engagement framework, which actually brings a lot of focus on in-country technical assistance, on and around immunization program. And with this new model, we were able to provide 350 boots on the ground to UNICEF and WHO. And apart from a lot of other non-traditional, new expanded partners. And I think these partnerships were tested during this pandemic. So we know that about the 350 staff members funded by us in several countries actually were used and leveraged by countries to provide them technical support in the wake of this crisis. And some of the other partners, for example, the CSO partners and all, they were really able to help countries do risk communication and really try and keep community trust in immunization going. Next. So and with all this, we were seeing some examples where we saw success in actually containing disruption of immunization services. So in Laopedia, for example, there was a successful nationwide launch of HPV with really pretty good coverage in some of their provinces. And similarly, Afghanistan, resorted to some very new, creative, innovative ways of avoiding disruption to routine immunization. And in Uganda, they did the same. I have many more examples that I can speak to, but really the message here is that if there is will in countries and if there is competent technical support from partners, countries are able to contain disruption to immunization services, and that creates hope and optimism. Next. So restoring immunization services is now a priority. And as Robin said, there is an opportunity for us to rebuild better. So the first thing which is extremely important from our perspective is enhanced focus on equity and gender. And we are really putting it on top of our list of priorities, because as Robin said, COVID-19 is exacerbating inequities. So the number of zero-dose children and under-immunized children is going to go up. Already we were not making good enough progress, but now, of course, you will see, a decline in our ability to actually reach this household. So it is critically important from our perspective that we focus on equity and actually mainstream gender, because we know gender barriers play a very powerful role in inequities. One thing that I would definitely want to emphasize, Robin presented these three key contexts, and I'm a member of ERG, as he referred to, and we said, yes, these are three important contexts: the urban slums and conflict settings, remote rural areas. But the data that he presented also shows that 50% of these zero-dose children are outside these three key contexts. And I think that's a very, very important thing to keep in mind. And as we did some further analysis, we found that 2/3 of these children actually live in households which subsist on less than $2 a day. So poverty is the biggest driver and determinant of this deprivation, multiple deprivations that we are talking about, including lack of access to immunization. So you go to any community, any village in any country, you would find 10% poorest households who are living in acute poverty, who are stigmatized and for a variety of reasons are unable to access services, including immunization. So this is going to be firmly our focus, and we would be working with partners to understand how we approach this issue. The solutions really have been eluding us. The second important thing, as Robin said, is tailored, integrated, efficient approaches. Now, these are not just words for us, because as he said, we really need to reimagine our approach to immunization. And we are very clear on that it cannot be more of the same thing, right? Or business as usual. So we need to go in for more tailored, targeted outreach, and we need to be much more stitched up and integrated, because and we also know that if we are serious about reaching the poorest households, then we have to enrich our offering. Because if you're just taking vaccine or immunization, and Naveen spoke so eloquently to vaccine hesitancy, and I saw this personally when we were fighting polio in India, that when we were approaching communities again and again with just polio vaccine, communities were very suspicious of the government agenda, because they thought that the government was not paying attention to any other need that they had. So I think the more we enrich our offering and broaden it, right? So with immunization, so first of all, with measles vaccine and polio vaccine, we bring other vaccines as well, but then go beyond vaccines to combine, whether it's deworming or supplementation or several other sort of value-added services, I think will really be key to our success, and efficient. And efficiency is an important thing, because when we are talking about fiscal stress, we have to be mindful of the fact that donor countries also, can you go back to the previous slide, Jessica? So to me, the point, the important thing to keep in mind is that even our donor economies are going to be under stress. So donors are not going to, so they committed $8.8 billion to Gavi, which is higher than what we asked for. So we exceeded our goal, but it's not certain that they would give us this money, and there will be huge pressure for us to produce results. So money is going to come only if we are able to demonstrate concrete results. And there is going to be a huge pressure to get more out of the money that they're giving us. So I think just keeping that in mind will be important. I'm not going to talk about hesitancy, rumors, demand already. That has been touched on. Financing, I have already said. I think for us, it is also important that we bring innovations and we broaden our partnerships. One thing that we have seen is that in fragile countries, there is a declining trend in immunization. And that is because we have not been able to engage with the right partners. We haven't been able to engage with humanitarian actors, agencies. We haven't been able to go beyond immunization within health sector, and we haven't been able to go beyond health sector to education and nutrition and several other agencies that can bring added value. So I think this is going to be a very, very important focus for us. And lastly, the learning agenda, because we know COVID-19 is an opportunity for us to really gather learnings. And, our focus would be on real-time implementation research, so that we continue to sort of interrogate local problems and bring some meaningful research to understand what is it that we need to do better going forward. And the next one is my last slide. Next slide. I just wanted to, next please, Jessica. So we also see that, so the next slide is about Cambodia. And I just wanted to again, go back please. And Cambodia is a very good example, right, of a country where they have done things extremely thoughtfully, and they converted COVID-19 threat into an opportunity. And I think we have these examples, and at the global level, we really need to understand this better and make sure that we inspire other countries likewise and actually promote peer-to-peer exchange. The last, and that's really the end of my presentation. The next slide, Jessica, is just a reminder that, like something that you said, Tobias, in the beginning, it is good for us to remember that for one COVID-19 related death because of exposure to routine immunization, over 100 VPD related child deaths are averted by sustaining routine immunization. So, we cannot afford not to invest in this agenda. Thank you.
Thanks a lot, Anuradha. Great to see what you're doing at Gavi, and also using the opportunities that we now get and tackling the challenges. I'm very happy to introduce our last speaker for today, Dr. Altaf Bosan, the National Technical Focal Person at the National Polio Emergency Operations Center in Islamabad, Pakistan. Altaf, a warm welcome. Altaf, we cannot hear you.
Just wait, sir. It's all right now? It's okay?
Now it's excellent. Perfect.
Okay, so my presentation is also on?
Yes, we can see it very well.
Thank you very much, sir. It's a good opportunity for me to be here in this forum, really speaking, and then this critical time when I think at the global level, I think every country is facing a serious problem with COVID. Definitely, I think that Pakistan is also part of that, and then definitely when you have a normal health system, and then you are also stuck with other important activities, immunization activities in the country. Really speaking, such type of, I think, the critical time that are the very important example of the countries to how to manage and how to address the situation. Yes, we have a good and a strong network of the surveillance in polio eradication initiative in Pakistan. And yes, immunization services network is also a very old one. Those are very much important. And here, during this COVID situation, the polio eradication initiative were involved in the surveillance activities of the COVID, as well as response to the community through the call center. We established here the toll-free number helpline that was responsible to really respond and also guide to the community in a different way about the hospitals, about the laboratories, because where they will go and then do this all exercise. So that was these two activities are the main activities which we have done during this period, and then those are still continue. And then every day data is being generated, and then made mostly in the National Emergency Operations Center for Polio Eradication, and that is being presented at the national level, and then yes, international level. So that is a situation. But because of this all, I think the involvement, the program, yes, the program really left the focus from the own activities, and also there was a fear and there was a critical situation, and nobody was really, I think, in a position to move in the field for the immunization services, and the maximum immunization activities are through the outreach activities for both program, for the SIAs as well as for the immunization, essential immunization purely on the fixed site in the outreach, and SIA the house to house. So this type of, I think, the situation was very critical for Pakistan, and yes, definitely there was a gap of, I think, at least the 5 months. We stopped the activities, all activities, and then that only the focus was over on the COVID situation and then supporting them. But definitely, I think we continue also our surveillance activities, and also on the ongoing activities which are through the, I think, the virtual meetings, communication, and then coordination. That was also a main important area of work. But definitely, because that it can't be, I think, for the longer period to continue that one. So then yes, the activities started. And here, because that I'm going to share with you because my main focus will be on the process to resume the immunization services, and then implementation on the resumption plan of the polio and also essential immunization. Yes, because on the global situation of the COVID, and then the problem which have been faced, the immunization services, how they have suffered. Yes, you all are the experts, and you know what is going on everywhere. But in developing countries, where I think already, I think we have a serious problem in the network. So then is a problem. So here, if you can see the risk, because during the period all, I think the activities were really disturbed, and as evident from the pandemic, the children become the most vulnerable group in these pandemics as a life-saving vaccination halt. Similarly, with the surge of COVID-19 cases, all vaccination activities in the country come to a standstill. Even the previous vaccine that Pakistan prepares for the target of approximately 8 million children stopped due to lockdown and suspension of the flight operations. Therefore, there is a huge risk of wild poliovirus transmission as well as other vaccine preventable diseases. There is a huge risk of contracting COVID disease in caregivers as well as health workers. Health workers are already struggling hard to keep themselves safe from the deadly virus. So here, if you can see the picture in front of you, so the lockdown situation, during the lockdown situation in March and April, the program has suffered a lot. And you can see I think you can see the antigen, how they have dropped down as compared to the January and February, and then now restoration through the outreach resumption plan. I will share you in my next slides. So here you can see, because the impact of global pandemic on immunization services, there had been a significant number of children left unvaccinated in April, and then you can see the 0.7 million, 0.5 million in every I think the antigen. That is this is the problem here. And then when the process of the resumption of the immunization activities, yes, that was started earlier. As you are very much aware, the oversight board also directed to all the activities. But yes, in second part of in this presentation says I'll give you a brief on how we prepared ourselves to resume the immunization services. The government organized a virtual meeting of the National Immunization Technical Advisory Group to agree on the roadmap of the resumption of the essential immunization activities. Because earlier, yes, those were suffered, and the outreach activities were really stopped. Only the fixed site activities, those were functional. A very detailed SOPs document was developed through the consultation with all provinces and stakeholders, keeping the guideline of WHO in mind. A comprehensive training program was undertaken to train the vaccination staff on infectious prevention and control mechanism. Masks, gloves, and sanitizers were made mandatory for the vaccinators during the vaccination exercise. Through the meticulous process of developing guidelines, training outreach sessions were resumed in June 2020. So this is the situation. And then if you can start from the outreach activities, and you can see, because in June, those had been started in 86 UCs. The pictures are in front of you, and you can see the vaccinator. Around 7,000 vaccinators have been involved, and then the sessions which were done. So those are 100 out of 124, 119,000. The sessions were conducted, means almost 96%. That is a successful. I think the history successful. I think the information for the country, because in 86, because we have 165 districts in the country. But yes, as I start from the high risk areas, the problematic areas, then we did this exercise. But you can see this picture in March and May, because when there was a lockdown, so it was dropped down less than 50%. Means really speaking, and then almost I think only the fixed sites were functional, but the rest activities were not functional. And you can see also the Penta 3 as well as, and this is the same situation for all antigen. This is not only one antigen. And here you can see that, because the process when the process was process of the resumption of immunization activities was started, and then see the successful in reaching zero dose children for RI, and you can see the percentage, because how it was improved immediately through this outreach activities, because you know that this is a special activity now, enhanced outreach activities, because that is the focus, and then we have supported to the vaccinators, and we have motivated to the vaccinators. We have given a maximum time to the vaccinators to go in the field and then complete your task, and then it was successfully done, and then it is continuously doing. And then we have also the resumption plan for the EPI centers with the support of Gavi and with the support of other organizations. We have started that one, as well as the refurbishment of the EPI centers in Pakistan. That is also a very important exercise for us, because you know we know what problems we are facing in the EPI centers. EPI centers were declared in the old time, and really speaking, I think the visibility of the EPI centers and also the comfortable place for the vaccinators, which will attract to the community. So that is very much important, and that exercise we have also started simultaneously. And here is the resumption plan of the SIAs, for polio eradication initiative. So definitely, because you know the following the instruction of the oversight board, and also because the technical advisory group is very much functional here, and we have also our own task teams, task forces at the national level. So the 6 months plan has been finalized, and that has been endorsed by the concerned organizations. So the first activity which is going on during these days, because in this week it was started from 20th, so that is a case response specifically addressing to the CVDPV in Pakistan, and then the target is limited at present, because you know the only 6 districts we have focused, and 169 union councils are included in this round. But yes, during this round, what we have also added also the integrated services as well. So I will share you in my forthcoming slides. So the next round is also in plan in August. That will also focus to the VDPV situation. And then later, because we have 3 nationwide activities, so we start from October, November, and December. So those will be done in the country, the whole country. The 40 million children will be the target in every round. But here we are going to also use the TOPV again. It was really, because you know it was closed in 2016, but it is going to bring on board. But there is a problem with VVM. But even then the country is trying its best to really, because to get a waiver for that, because you know now in this year it will be difficult to have a VVM TOPV with VVM. But it will be managed, because this is a demand of the time, and then yes, government will give us the waiver. So this is the 6 months plan for the SIAs here, and ISD, yes, because the technical advisory group has really advised to laser focus on high risk areas that the polio program must support the community in other services as well. And definitely, because we have other services, mainly because you know now here because of the COVID situation, yes, we are supporting not only the workers. Yes, we are supporting workers in the PPE, mostly the masks, the sanitizer, and also the teams. We are also using the gun temperature, because to check the temperature of the family whose children are being given polio drops. So because we are trying our best to manage, and then also the masks and the soaps we are distributing in this round to the community. Every house we have fixed some amount of the soaps and also the masks to distribute them. So this kind of exercises are going on, and then we have also another important project, Recipe 3. It was started discussing, and then it was started in bringing on board in January, and then the series of meetings were done till March. But after that, really speaking, because of the COVID situation, again it was stopped. And now what we have started from the 6 union councils, super high risk union council, out of 40 super high risk UCs, because we have a 40 super high risk UCs in the country. And now this DCP package, because antenatal care, postnatal care, wash, nutrition, and then health services, those are being given through this one. But we have started we are going to start this package.
Dr. Altaf? I have some problems with the connection.
Right, just I think it's okay. So if you can see this one, so the national here the government is also involved. We have also the task. Because the national coordinator, Prawns, and an ISD task team. I am also chairman of the ISD task team here at the national level. So what is our role? Because we have a plan. The important, I think, the area which I want to share with you, the super high risk use is plan for the essential immunization. The 40 super high risk uses with a series of the activities which we have done here, where the BMGF and all partner agencies were involved, and those are on board. We have endorsed at the national level, and then we have sent those one to the provincial offices, and mostly Sindh has endorsed those one, KP has endorsed those one, and now we are in process of the signing of the letter of intent, which have been sent by the BMGF, because it will be done with the ministers as well as the BMGF, Dr. Kirishilias. So they will sign it. So this kind of activities are going on, and we finalize the targets for the impact level indicators for each of the interventions, and then formal reach to LHW, and then we have also requested to the provinces to bring on board and then fill the vacant positions which are for the vaccinators, which are for lady health workers. So and also refurbishment of the EPI centers. We need to get a support from the provinces as well. UNICEF, yes, demand for vaccines and community engagement that is involved over there. WHO, because I'm not going to, you are very much aware of that, and then here is a partnership involved in it, and then really we are proud and we are happy, because all, I think, the organizations are very much supportive to Pakistan. But this is the time to restore the situation. Yes, thank you very much, and I'm ready to respond any I think question or comments or anything which is at your
Thanks
level.
a lot.
And I'm sorry. Another, I think, the important activity recently we have done here, really, which I want to share with you, because you know the Aga Khan University that is going to do the third-party vaccination immunization coverage survey. This is a 5-month survey, start from August to December. Government has approved it, and yesterday we have also sent the instruction to all districts, because it will be done in whole country. So that is the last, I think, the activity which I want to share with you about the immunization. Tobias, it's up to you now.
Thanks a lot, Dr. Altaf, and thanks for sharing concrete examples from Pakistan, how you're handling the situation, and also about the survey now coming up. Time is running short, but we have the time for a couple of short questions, and I open up to all the panelists to answer the questions. And the first question is very concrete. It's regarding the zero-dose vaccination children, and the question is from Aditya Mohapatra, and it's, as per my knowledge, zero dose is the dose given within 24 hours of birth. Has the nomenclature changed to non-vaccinated child? Maybe you want to start, Robin.
Yeah, I can answer this very quickly. This is a great question, and I should have probably clarified this earlier. The zero dose vaccination for different antigens are still in place. So here we are not talking about zero dose vaccine. We are talking about zero dose children. So zero dose children are defined by those children who have not received a single dose of DTP1, right? So zero dose is no DTP. And then we are extending this definition now to zero dose community. The community is where a large number of zero dose children are clustered. Over.
I can add here. Yes, definitely. Robin, yes, Robin is really the expert in this all. But here, I think the little bit definition is changed here, because you know we are focusing mostly because this information we are providing to the immunization program, and the polio emergency program is providing them. Then I think we are also focusing on if the zero dose is there, it means not a single dose, either it is a OPV, it's a BCG, it is a DPT, or any dose is not being given to, because the child has not in excess for the immunization services. So that is really, because you know the definition.
Yeah, I was just clarifying the data that I presented. The definition was DTP1, which is used as proxy for unvaccinated. You're absolutely right, Dr. Bosan. Zero dose is important for every antigen as well.
Yeah.
And then thanks a lot for the clarifications there. And I think it's very important that we keep it clear what we discuss. And then a question here. Now, Anuradha from Gavi had to leave us, but the final question to all of you. This is more related to the COVID-19 vaccines, but there have been a lot of questions related to that. So the final question will be related to that. And it's from Kwabina Owusu-Kwei. And that's, what are some of the modalities and approaches being put in place by UNICEF and Gavi and WHO to ensure equity in supply of potential COVID-19 vaccines to low and middle income countries?
Yeah. I can take that on behalf of Anuradha as a member of the Gavi Alliance as well. And I saw a couple of questions directed to Gavi as well. You know, a couple of things here. You know, the COVID vaccine, a huge, big infrastructure is being created around. It's called the ACT-A, the acceleration of COVID tools. So basically a mechanism for distribution of innovative tools for vaccines, diagnostics, and therapeutics for COVID. So there's a big, if you Google ACT-A, you will be able to find all the information on that. So there is a mechanism being developed under that called the COVAX facility, which is looking at both pull and push financing to be in place early on to both stimulate vaccine development, manufacturing at scale, and then eventual financing for countries to actually procure and roll out these vaccines. This is going to be for mechanism for all countries of all income levels. It's an extremely complex piece of work. I mean, I think we can dedicate an hour session on that, but it's been led by WHO, Gavi, and CEPI, the Coalition for Epidemic Preparedness Innovations. There was also a question on the economic downturns and redefining of Gavi criteria for eligibility. I think this is a great question. At this point, Gavi's support is extending to the Gavi eligible countries and the Gavi transition countries. We are also looking at some of the smaller countries that fall through the cracks, like the Pacific Island countries that we are trying to include it. There is now parallel discussion going on what to do with some of the never Gavi eligible countries that have weak systems, high number of unvaccinated or zero-dose children, and a strategy for support. So some of these never Gavi eligible countries will be put forward to the board in December.
Thanks
And
a lot, Robin.
I think just to stress one point, when I was presenting the WUNIC data, one thing that's really striking for this group of participants here is that we are seeing a very worrying decline in vaccination coverage, even pre-COVID, in middle-income countries and regions with high number of middle-income countries. The Americas have seen a 10 percentage point drop in DTP3 coverage. Similar in countries in Europe. So this is not a low-income country problem. We have to look at it across the board. Over.
I think time is flying and we need to wrap up, and there are still many questions and the discussion can go on for a long time. I would like to thank all the speakers so much for taking the time and to participate all the way from New York to Pakistan and India and Switzerland. And then the presentation and the webinars, they will be posted on the Coalition's website and the discussion can continue there. And before we finish, I would like to hand over to Sulfi for the final words. But again, thank you so much to all the participants and the speakers.
Thank you very much, Tobias, for moderating the session. And I'd like to particularly thank the speakers who handled a variety of topics related to rebuilding immunization systems in the wake of COVID. This is our second webinar in the series of activities of the Coalition of Centers in Global Child Health. And we will soon be having our third webinar at the beginning of August, so watch out for that, which will be on child and adolescent health, including many issues related to school-age children and how has COVID impacted them, and we could find a way beyond. And this series will continue until the end of the year in looking at various aspects of health and child health in relation to the pandemic that we face. So suffices for me to thank everybody, including our wonderful panelists and Tobias for leading this. God bless, and thank you very much for your participation.
Thank you. Goodbye.
Bye-bye.